majority of them, which makes sense because you induce induction and maintenance as well. All right? Just to say it out there. Hypotension by procedural groups, okay? What are the top 6 or 7 of them? General surgery, orthopedics, vascular surgery, urology, cardiothoracic surgery, or otorhinology, neurosurgery, gyne as well. Are the medications used plays a major factor in hypotension? Of course, makes sense. What are the top 5? Of course, IV anesthetics, opioids, benzos, inhalational agents, and vaporizer incident. So we place this in our book, in the chapter as well. We place other factors that can actually cause all this hypotension. Everything is written. I know it's a little bit microscopic. All right, just want to emphasize hypoventilation, hypotension, hypovolemic, hypoxic, hyperthermic, acidosis, increased intrathoracic pressure, pain, arousal, volatile anesthetic, seizures, and PEEP are actually the top things that will affect our brain. All right, of course, we know this also. It's good, it's nice to have a review. Mechanisms of action, cerebral physiologic effects, and main advantages, disadvantages of sedatives, analgesics, and patients with acute brain injury. So emphasis on the CNS effects as well. Just have a peripheral brain. Everything is already in apps and so on. Barbiturates, morphine, dexmedetomidine, ketamine, of course, fentanyl, inhaled anesthetics. Okay, causes of tachy, brady, and hypotension as well. What are the top 5? Of course, the drugs, regional anesthetics, hypovolemic, airway, and allergy. Okay, also in the book, affects cerebral physiology. Top 3, 4 things that can actually affect the pressure is barbiturates, benzos, desflurane, dexmedetomidine, a little bit actually, and propofol. So what is the target map and how long should it be down for the brain to be affected? Famous question. So what is the target map do you usually do? How low can we actually go? And how long can we actually go for us to affect the brain? So again, I showed this earlier because this is very, very important. Well, the review article said the EEG, if you hook a patient on an EEG, frequently becomes isoelectric during cerebral perfusion at arterial pressures below 50. Isoelectric is equivalent to brain death, my friends. So you can just imagine, stay away from 50 below because there are a lot of evidences on this already. Despite the oxygenation that's okay, despite the hypothermia, despite the CO2, once you're hypoperfused, goner ka pa rin. On the other side, decrease more than 30% of the map from baseline. So another way of looking at it, there's a study on it by the American Society of Anesthesiology, 2012. They thought of, what if from baseline we go down by 30%? Which sounds reasonable. How about the latest one is 2018 actually. They said, don't go less than 65 in terms of MAP for 10 or more minutes during cardiopulmonary bypass is associated with an increased risk of stroke. When you look at the autoregulation curve, it actually makes sense, right? So don't push it too much. Always look at this graph. Again, if you do have a mild stroke, again, for brainwashing, if you do have a severe stroke, the more you are dependent on the MAP. Are we capable of monitoring? Is there an intra-op monitoring? Well, there is actually. There's what we call somatosensory evoked potential. It's only one Meralco that we can actually do intra-op. We do it, but for the indication of the spinal cord. But when you look at hypoperfusion, this can be used. And we look at the amplitude of the waveforms. So the neurologist who's staying there all throughout will actually tell you, hey, the amplitude is going down, you might want to go up a little bit. It's very nice. But you're talking only about one Meralco. Is it helpful? It might be helpful, at least a glimpse of the brain, because your patient is totally sedated. How about an EEG? Can you do an EEG intra-op? We can, right? But who is the neurologist who will stay inside the intra-op monitoring? Probably it's still evolution. Probably we need to teach all the residents and so on how to go about it because we're only 500 in the country. Next, if you do have an EEG you have hypoperfusion, the EEG is down, what happens to your patient post-op? And these are like a few patients when I was born, 1970s. They already saw coma patients, seizures, temporary stupor, early organic brain syndrome, initial stupor, left-sided seizures, right hemiplegia, and so on. You don't want that once they're awake. So again, the EEG goes down, the amplitude of the electrical charges of the brain goes down, and then we're in trouble. Again, some patients of them died actually. When you look at it, you have laminar necrosis in the brain, and then your Purkinje fibers are donor. Okay, this only shows you only a few patients. When you look at it, when you have hypotension, the hertz, the normal hertz in our electrical charges in the brain is about 8 to 12. If you're an elderly, it's acceptable about 7, but patients actually goes down until 2 hertz only. So that's not a good thing. Can we actually do TCD or transcranial Doppler? One thing is looking at the electrical charges in the brain. Another thing is looking at the NAWASA, which is the cerebral blood flow. Look at the TCD. We can, if you do have a TCD, now again, you have a neurologist on board or a tech that we can teach actually. Again, we're evolving. It can be done. I just want to show you, when you look at the graph is in our book as well. When you look at it, the to and fro flow tells you also your patient is a goner. Okay, the to fro flow, the waveform. Okay, one thing is looking at the electrical charges, another thing is looking at the blood flow. I love neurology. It's Meralco and NAWASA, isn't it? How about cerebral oximetry? So this is what you call NIRS. It's still under study, but it's good to have it, honestly, especially when your patient is totally sedated, whether or not they are anesthetized or in coma. So near-infrared spectroscopy. So this is ongoing. People are still studying it, but very nice. It tells you oximetry. So one thing is looking at electrical charges, cerebral blood flow. Now you can say the oxygen in the brain. Because remember, the pulse oximeter is not that sensitive when it comes to the brain. Even the glucose, mind you, that's another talk. So what is a reasonable approach? Again, do the basics. Free anesthetic, I know everybody's excellent in this. Taking, don't disregard it, please. Syncopal attacks, dizziness, double vision, numbness, weakness. I PE exam. If stroke patients and with known intracranial and carotid stenosis, the aim for MAP is at least, it's reasonable to have MAP of more than 60. Because if you aim for more than 50, you might be in trouble. You're too close for you to maintain it. If patient is high risk for stroke, if available intra-op monitoring, use it. Or invent it in your hospital, because we're still inventing it also. So shorten the duration of relative hypotension as much as you can. Work with your surgeons, neurologists, especially if you're best friends. Tell them, can you just make it fast? And consider the kind of procedure as well. Post anesthetics, again, do your PNR exam as well, of course. So just to emphasize, all the patients that got an EEG problem, they have a prehistory of syncopal episodes, carotid bruit, hypertension, and so on. So do your homework again, understanding your patient. Do your sperm, all right? Not that sperm again. The last time I went to anesthesia obstetrics, now this is the anesthesiologist. Just do a quick neuro exam. Do the sperm, sensorium, P for pupils. Nice pen light, please. Not ever ready. Extraocular muscles. Somebody might own ever ready here now. I'm sorry. And then R for respiratory. You guys are not laughing, no? The